So hypertension, mild hypertension can be controlled by salt and water restriction. Apart from that, antihypertensive drug we can give nifedipine and amlodipine, or diuretics can be given. Beta blockers and ACE inhibitors causes hyperkalemia, so will increase the potassium level. It's very bad. And then patients with hypertensive emergency, suddenly we have to give IV nitroprusside or labetalol, which is a beta blocker. Okay. Left ventricular failure, the hypertension should be controlled and IV furosemide given to induce diuresis, leading to improvement of the heart failure. If diuresis is not noted, dialysis is initiated. Respiratory support with PEEP, that is positive end expiratory pressure, may be necessary. So dialysis பண்ணனும். Okay, முதல்ல வந்து we give diuretics. First diet, அப்புறமா diuretics, and then antihypertensive medications. All these fail, or just you give diuretic and it does not work, then dialysis போயிடணும். And respiratory support using PEEP has to be done. Prolonged oliguria treatment as outlined above should be continued, and levels of BUN-C, blood urea creatinine, have to be monitored. Electrolytes are also monitored. Dialysis is needed in children with severe renal failure, prolonged oligoanuria, okay, fluid overload, and life-threatening electrolyte disturbance. Occurrence of secondary infection should be avoided. So, on the dialysis, okay, for prolonged oliguria, or if it's a severe renal failure, prolonged oliguria or prolonged anuria, fluid overload, life-threatening electrolyte imbalance, அப்போ வந்து we have to give dialysis கொடுக்கும்போது prevent infection, so like secondary infections have to be avoided. Okay. Okay, so that's about the management. Diet, diuretics, hypertension, left ventricular failure, prolonged oliguria. Outcome and prognosis. Acute post-streptococcal glomerulonephritis has an excellent prognosis in childhood. The symptoms begin to resolve in the first week itself, with loss of edema, fall in the BP. Gross hematuria, significant proteinuria disappear within 2 weeks. First week edema and hypertension will go. Next week proteinuria, hematuria will go. Okay. Although microscopic hematuria and slight proteinuria may persist for several months, but major அப்படியே ஒரு 2 weeks சரியாயிடும். Hypertension will subside within 2 to 3 weeks, but rarely may persist for several weeks. Patients with AGN of non-streptococcal origin have variable and unpredictable outcome. These cases need regular and close follow-up over several years with periodic urinalysis and measurement of BP. Renal biopsy is rarely indicated in those suspected to have PSGN, except when the renal function is severely impaired beyond 7 to 10 days, or serum C3 remains depressed beyond 12 weeks. Patients with features of systemic illness, SLE, require a renal biopsy. So once again, reviewing the indications for renal biopsy in case of AGN, acute glomerulonephritis. So systemic features like fever, rash, joint pain, heart disease. That is one. Second is absence of serological evidence of streptococcal infection, that is normal C3. Okay. Third is mixed features of nephrotic and glomerulonephritic syndrome. Fourth is high levels of BUN-C or anuria requiring dialysis, that is RPGN, ரொம்ப rapid progress of the disease. Okay, and the clinical features, serology, differences பண்ண முடியாது. And then BUN-C and dialysis requiring RPGN. Delayed resolution. So more than 7 to 10 days if there is oliguria or hypertension, that is HO, 7 to 10 days. Or beyond 2 weeks there is nephrotic range proteinuria. Or beyond 3 to 4 weeks there is hematuria. So 2 weeks protein in the P, 3 to 4 weeks blood in the P. And then 3 months low C3 levels, 6 months persistent proteinuria. All these are the indications of renal biopsy. Okay, thank you.